After studying this module, you will be able to learn about classification of sleep disorders, dysomnias and hypersomnias, understand parasomnias and sleep apnea. Humans spend about 1/3 of their lives in sleep. Optimal sleep is considered to be restful and refreshing under most circumstances with good sleep continuity, efficiency and short latency. Sleep is not a consistently smooth process. It shows a rhythm of various stages throughout the night. Every stage has a specific neural base. Any damage to the areas of brain controlling sleep may lead to some kind of disorder. Specific dysfunctions have been identified as sleep disorders. The frequency of people reporting sleep disorders is very high. A sleep disorder is any condition that involves difficulty experienced when sleeping. Such disorders often result in daytime fatigue, causing severe distress and impairment to work and social or personal functioning. Sleep disorders are extremely common in the general population and can lead to significant morbidity. Sleep disorders may cause or exacerbate pre-existing medical and psychiatric conditions and are associated with high rates of depression, anxiety and impaired daytime functioning. They may also lead to poor occupational performance, motor vehicle accidents, cardiovascular and endocrine disorders or heightened pain perception. Although many sleep disorders can be diagnosed clinically, some require further evaluation in a sleep laboratory. Classification of sleep disorders. The classification of sleep disorder is necessary to discriminate between disorders and to facilitate an understanding of symptoms, etiology and pathophysiology that allows for appropriate treatment. The earliest classification systems, largely organized according to major symptoms, insomnia, excessive sleepiness and abnormal events that occur during sleep, were unable to be based on pathophysiology because the cause of most sleep disorders was unknown. The first major classification of sleep disorders, the Diagnostic Classification of Sleep and Arousal Disorders, published in 1979, Association of Sleep Disorders Centers 1979, organized the sleep disorders into symptomatic categories to form the basis of the current classification systems. In 1990, the International Classification of Sleep Disorders was published through the efforts of major international sleep societies at that time, such as the American Sleep Disorders Association, European Sleep Research Society, Japanese Society of Sleep Research and the Latin American Sleep Society. The ICSD classification, developed primarily for diagnostic, epidemiologic and at the same time research purposes, has been widely used for clinicians and has allowed improved international communication in sleep disorder research. The International Classification of Sleep Disorders, 2nd edition, was published by the American Academy of Sleep Medicine with the goal to standardizing definitions and creating a systematic approach to diagnosis. The ICD-2 lists 81 sleep disorders in 8 major categories: insomnias, sleep-related breathing disorders, hypersomnias of central origin, circadian rhythm sleep disorders, parasomnias, sleep-related movement disorders, unclassified disorders and other sleep disorders. In addition, there are 13 diagnostic items that include sleep disorders associated with disorders classified elsewhere and psychiatric disorders frequently encountered in the differential diagnosis of sleep disorders. DSM-5 classification of sleep disorders, parasomnias and dysomnias. Disturbances of sleep in the DSM-4 were described in broad terms as the dysomnias, that is conditions involving abnormal sleep amount, quality or timing, and the parasomnias concerned with abnormal events or behaviors involving the sleep cycle or sleep-wake transitions. Although the distinction is no longer central to the DSM-5 organization, The terms retain their descriptive value in discussing the sleep or wake disorders as described in the table. People with sleep-wake disorders can have significant life impairment similar in degree to chronic health conditions like diabetes, heart disease or arthritis. Often the symptoms presented by people with sleep disorders resemble those of other mental disorders such as panic, anxiety and depression, and may be misidentified as a result. Correct diagnosis may be difficult, requiring extensive information about history and evaluation in a sleep laboratory. Nonetheless, structured interviews using DSM-3R criteria produce good to excellent inter-observer agreement across different disorders, with highest agreement on insomnia and hypersomnia. The only category with poor reliability was circadian rhythm sleep disorder. Sleep-wake disorders were not assessed in the DSM-5 field trips. Many people experience periodic sleep disruption or unusual sleep experiences but rarely seek treatment for the condition. Because sleep patterns are so variable and symptoms are so common, the prevalence of most sleep disorders is uncertain. Diagnosis of these conditions should be restricted to those individuals for whom the sleep disturbances produce significant distress or impairment in important areas of functioning. Still, sleep problems are notable among the elderly, with almost 50% complaining about chronic sleep difficulties. It is likely that these conditions are underdiagnosed among the general population. Dysomnias and insomnia disorder. Insomnia is one of the most commonly reported sleep disorders. In insomnia disorder, individuals have difficulty falling asleep or remaining asleep, or they are unable to get back to sleep after early morning awakening. The major symptom is the inability to fall asleep, which is sleep onset insomnia, or to stay asleep, which is sleep maintenance insomnia. It causes great distress and exhaustion in the individual. People commonly complain that the sleep they achieve is non-restorative, that is, restless and poor quality. It is more commonly reported by people who are older, female, or users of tobacco, coffee, alcohol, etc. Sleep onset insomnia may be caused by situational factors like shift work, time zone changes, environmental changes like moving to a new place. The sleep maintenance insomnia is related to a complex of factors such as situational, neurological, psychiatric, medical and current stresses of life. Not being able to sleep is a serious problem. It has been reported that people who sleep for short periods have a higher mortality rate than those who sleep regularly for 7 to 8 hours every day. Insomnia is difficult to diagnose due to a state called sleep state misinterpretation. The individual may report that he did not sleep, but the EEG records may show that he did. Insomnia cannot be diagnosed only on the basis of verbal reports of the individual. He may have been sleeping without knowing it. Besides, the need of sleep varies for individuals. Drug dependency insomnia has also been recognized as a disorder. It is also known as iatrogenic or physician-induced insomnia. It is characterized by sleepiness due to taking drugs for sleep. Such drugs cause dependence and their need increases to a level that could be highly dangerous. Besides, they may cause grogginess, inability to concentrate, and lack of motor coordination the next day. Such hangovers will further impair sleep patterns. Insomnia may also be caused by nocturnal myoclonus and restless leg syndrome. The former is a periodic twitching of the body, particularly legs, during sleep, and the latter is characterized by tension or uneasiness in the legs, which does not allow an individual to fall asleep. The causes of such disorders are not very clear. Added to above is the category of neurotic pseudo-insomniacs, where anxiety and other psychological problems prevent an individual falling to a restful sleep. Several drugs have been developed for insomnia. Most of them disturb the cycle of sleep, particularly REM. The hormone melatonin has also been tried, which produces drowsiness by lowering body temperature. The best prescription, however, is to follow a regular routine of going to bed at the same time and in the similar surroundings. Hypersomnolence disorder. Hypersomnolence disorder consists of excessive sleepiness despite receiving at least 7 hours of sleep during the main sleep period. Those with the condition may sleep for more than 9 hours without finding sleep refreshing and then have difficulty awakening. Daytime naps are not experienced as restorative or refreshing. Unintentional sleep may occur, especially when the person is in low stimulation or inactive situations. Individuals struggle to remain alert, but efficiency, concentration and memory are typically impaired, as are social and occupational functions. Specifiers for the condition include comorbidity with another mental disorder, medical condition or sleep disorder, duration specifiers for acute, which could be less than 1 month, subacute 1 to 3 months and persistent more than 3 months, and severity indicators for mild, that is alertness difficulties 1 to 2 days per week, moderate alertness difficulties 3 to 4 days per week, and severe alertness difficulties 5 to 7 days per week, as per the American Psychiatric Association in 2013. During one type of recurrent hypersomnolence disorder called Klein-Levin syndrome, individuals may spend as much as 20 hours per day in bed. Narcolepsy. Narcolepsy is a neurological disorder characterized by a sleep attack. The individual suddenly falls to sleep while awake and at any time, however inappropriate it may be. In most cases, it is preceded by monotonous conditions. The individual feels refreshed after getting out of it. The sleep attack may last from a few seconds to several minutes. One of the major conditions related with narcolepsy is cataplexy. It also happens during the wakefulness state. The individual falls down flat and motionless. He is fully conscious and therefore he is extremely terrified of his situation. He is extremely terrified of his condition. Cataplexy is generally precipitated by an emotional arousal like extreme anger, fear or aggression. It may even be initiated by a strong laughter. Strenuous physical effort has also been found to have initiated such an attack. It may last for a few minutes, after which the individual will himself get up. Yet another condition of narcolepsy is sleep paralysis. It is less dangerous since it occurs just before or just after going to sleep. The person is paralyzed as he is lying down in his bed. Sometimes the dreaming component of this state also intrudes in. The person has vivid images which may cause terror. They are called the hypnagogic hallucinations. The person in this state may be quickly awakened by tactile or auditory stimulation, that is, by touching him or by calling his name. Narcolepsy usually manifests itself during the ages 15 to 25 years and continues throughout life. Narcolepsy is normally accompanied by excessive daytime sleepiness. Several strains of dogs may also exhibit symptoms of narcolepsy. Research on the sleep patterns has indicated that narcolepsy is a condition where REM sleep occurs without having been preceded by slow wave sleep, which is the normal pattern. The bout of REM sleep may appear suddenly during the waking hours, exhibited in the form of cataplexy. It is true of sleep paralysis and hypnagogic hallucinations also. Sleep paralysis is caused by the pontine center continuing to impose paralysis for a short while even after awakening from an REM episode. The brains of narcoleptics have poorly controlled neural mechanisms which coordinate to produce various aspects of the REM sleep. Narcolepsy has been described as a genetic disorder. Narcoleptic sleep attacks can be diminished by the stimulants. The antidepressant drugs have also been found to be useful in controlling this disorder. Scientists are trying to develop synthetic drugs to stimulate hypocretin receptors, which may provide relief of symptoms in narcolepsy and also combat daytime sleepiness in people without narcolepsy. Breathing related sleep disorders. The central feature of a breathing related sleep disorder is sleep disruption leading to excessive sleepiness or insomnia caused by a breathing difficulty. Most often the breathing difficulty is sleep apnea, in which breathing ceases during sleep. Sleep apnea is characterized by frequent episodes of cessation of airflow during sleep. The person wakes up gasping for air, is heavily breathless and takes some time to resume normal breathing. After some time there may be another such episode. It becomes serious when the frequency of apnea is 5 or more per hour. The person never gets up fully refreshed and suffers from the daytime sleepiness. There may be hundreds of apnea episodes per night, each of a duration of 1 to 2 minutes. In addition to apnea, hypopnea, a reduction in airflow related to unusually slow or shallow breathing, and hypoventilation, which is abnormal blood levels of oxygen and carbon dioxide, also constitute the respiratory events that may disturb sleep in these conditions. Breathing is a reflex. In young children, it may not be fully developed. As a result, there may be death due to respiratory failure. This is known as the sudden infant death syndrome or SIDS. Apnea is a typically REM sleep disorder. During REM sleep, the muscles relax. In some persons, they may relax to a much greater extent. Progressive relaxation of the muscles of chest, diaphragm and throat muscles obstructs the airways and causes choking. It may be accompanied with loud snoring. It is more common in the obese, though it happens in others as well. Due to restricted breathing, the level of oxygen in blood goes down and that of carbon dioxide goes up. The latter stimulates chemoreceptors, neurons that detect deficiency of certain chemicals. These act like baroreceptors and signal the brain about oxygen deficiency. The brain sends signals to the centers which produce awakening. The person gasps for air, the level of oxygen rises and he goes back to sleep. After some time, the cycle begins again. The most common form of breathing related sleep disorder is obstructive sleep apnea, hypopnea, involved repeated obstructions of the upper airway accompanied by loud snoring. This occurs during REM sleep when the upper airway collapses. Obstructive sleep apnea, hypopnea, is more common among middle-aged, overweight males and in children with enlarged tonsils. It tends to have a gradual onset and a chronic course, and it can contribute to premature death by heart arrhythmia or cardiovascular disease. Weight loss and continuous positive airway pressure or other techniques to keep the airway open are the most effective treatments. A much more rare breathing related sleep disorder is central sleep apnea, in which there are 5 or more apneas per hour of sleep not related to obstruction. In central sleep apnea, the brain fails to send the necessary signals to the respiratory system to breathe. Abnormalities or damage of the brainstem is important in this context. In most of the cases, however, the two conditions are mixed. They also interact with each other and make each other worse. Apnea results in poor concentration, memory, and several other neuropsychological deficits. Sleep-related hypoventilation need not involve apneas, but rather shallow or decreased breathing that leads to elevated levels of carbon dioxide levels in the blood. Sufferers complain of frequent awakening, sleepiness, insomnia, and headaches. The condition is thought to be uncommon but may be increasingly related to rising obesity and chronic obstructive pulmonary disease rates. Causes of apnea are very poorly understood. However, certain treatments are found to relieve the symptoms. Insertion of a removable tube in the throat can restore a normal sleep pattern and eliminate daytime sleepiness. Another treatment is also through a mechanical device called the Continuous Positive Airway Pressure (CPAP). Breathing through this machine maintains air pressure in the airways and prevents the collapse of those airways. Circadian rhythm sleep-wake disorders. Circadian rhythm sleep-wake disorders involve a persistent sleep disturbance due to a mismatch between the person's internal 24-hour sleep-wake cycle, that is, the circadian sleep-wake pattern, and the schedule required by the person's environment. As a result of mismatch in cycles, affected people usually experience insomnia at some times of the day and sleepiness at other times, with significant distress or impairment of functioning evident, for example, falling asleep at inappropriate times. In some types of circadian rhythm sleep-wake disorders, an individual may feel locked in to a cycle of unusually late sleeping and awakening, unable to adjust the cycle to an earlier one, such as that required for a job, which could be delayed sleep phase time. In other cases, people may experience earlier sleep onset and awakening with the inability to adjust to the conventional later sleep-wake times, that is, advanced sleep phase type. The condition may be generated by certain work schedules, especially night shift work type, or appear as a lack of discernible sleep-wake rhythm with sleep fragmented into at least 3 different periods during the day, irregular sleep-wake time. In another pattern, non-24-hour sleep-wake time, the sleep phase gradually increases and drifts out of 24-hour alignment so that sleep time moves into daytime hours. This subtype is particularly common in blind or visually handicapped persons. The severity of sleep disruption appears to increase with age. Some forms, example shift work type, show reversal of symptoms with schedule changes, while the delayed sleep phase type may last for decades. The prevalence of circadian rhythm sleep-wake disorder is unknown. Melatonin, secreted by the pineal gland, helps to regulate sleep-wake cycle rhythm. It appears to be beneficial in the treatment of circadian rhythm sleep-wake disorders. Parasomnias. They include abnormal sleep behaviors. Some examples are non-rapid eye movement sleep arousal disorders. The non-rapid eye movement sleep arousal disorder involve incomplete awakening from sleep accompanied by sleepwalking or sleep terrors. The DSM-5 diagnostic category is a combination of 2 separate DSM-4 disorders, nightmare disorder and sleep terror disorder. Usually, the incomplete awakening occurs in the first third of the sleep episode and tends to be brief, that is less than 10 minutes, although longer up to 1 hour events may occur. Typically, in the sleepwalking type, the eyes are open. The event may begin simply and become progressively more complex, including getting out of bed and leaving the room. Sleep terrors involve a strong sense of dread and a compulsion to escape, but the person usually does not wake completely and returns to sleep. In both type of episodes, persons do not remember the event the next morning. Sleepwalking involves repeated episodes of complex motor activities which begin during slow wave non-REM sleep. Depending on the severity, the motor activities can range from sitting up in bed to carrying on conversations, eating food, leading a building, or even operating machinery. Episodes usually terminate with return to full sleep, sometimes in new or unfamiliar locations. If awakened, which is difficult, the sleepwalker is typically confused for several minutes and does not report dreaming or awareness of the event. During sleepwalking episode, the individual commonly has a blank face and is relatively unresponsive to attempts to communicate or be awakened by others. The person may talk or even answer questions. but a genuine dialogue is usually not established. Although their eyes are typically open, sleepwalkers may be clumsy. Some injure themselves by walking into walls or falling through windows. Occasionally, sleepwalkers may strike out at others, particularly if sleep terrors are also present. There have been reports of complex sexual or violent behaviors, including homicide and rape, occurring during episodes of sleepwalking. Although traditionally considered extremely rare, sleep-related violence may be greatly underreported. However, the majority of such cases occur in young to middle-aged men with a history of sleepwalking. Sleep-related eating may also occur during sleepwalking episodes, especially among females with varying degrees of amnesia. In sleep terrors, individuals awake from sleep abruptly, usually with a cry or panicky scream. They show intense fear and autonomic arousal such as rapid heartbeat, rapid breathing, pupil dilation and sweating, and are generally unresponsive to efforts by others to awaken them. They may actively resist attempts to comfort or hold them by swinging, punching or rising from the bed and fleeing. These acts can result in physical injury to self or others. In most episodes, individuals do not fully awaken and return to sleep. However, if they fully awaken, they do not recall dreaming, apart from fragmented images and a sense of terror. The next morning, there is amnesia for the episode, which usually does not occur more than once a night. Episodes recur after several days or weeks and are made more likely by fatigue, stress, and alcohol or sedative use. Rapid eye movement sleep behavior disorder. A provisional condition in the DSM-4, rapid eye movement sleep behavior disorder, was elevated to a parasomnia in the DSM-5. It consists of complex motor activity or vocalizations that occur during REM sleep and are associated with vivid dreaming. Normally, skeletal muscles are paralyzed during REM sleep. In those with rapid eye movement sleep behavior disorder, that paralysis is absent, allowing people to essentially act out their dreams. Violent activities such as punching and kicking sometimes occur during episodes. Emotion-laden, loud shouting may be present during the episode. The condition may precede or accompany the development of some neurodegenerative conditions, including Parkinson's disease, and it may be more likely in children with autism. Its prevalence is about 0.5% of the population, but it is more common in the elderly, especially men. Nightmare disorder. Those with nightmare disorder repeatedly experience frightening dreams that result in awakening. Individuals rapidly become alert and oriented after waking and can recall the nightmares in detail. Most often, the nightmares involve threats to the person's safety, security, or self-esteem, and those intense dreams or sleep disruption they produce cause significant distress or impairment for the individual. The dreams in nightmare disorder usually last longer than 10 minutes and happen during REM sleep, which increases in the second half of the night. The nightmares often are lengthy, elaborate, and terrifying and may recur several times in a night. Themes about attack, injury, pursuit, and personal failure or embarrassment are typical. Upon wakening, the person may be anxious and fearful and can recall the sequence and imagery of the dream in detail. The most common impact of recurrent nightmares is subjective distress. Some individuals may avoid sleeping and daytime functioning may then be impaired as a result of sleepiness. Nightmare disorder most often occurs in children who have been exposed to severe psychosocial stressors. The dreams usually begin between 3 to 6 years of age and increase in prevalence and severity into early adulthood. Females experience nightmare disorder up to 2 times more often than males. Depression, substance use disorders, and personality disorders may be associated with the condition, but PTSD is accompanied by nightmares nearly 5 times more often than any other disorder, and some consider PTSD as predisposing factor for nightmare disorder. The incidence of nightmare disorder is unknown, although 50% of adults experience occasional nightmares and up to half of children ages 3 to 5 experience nightmares severe enough to disturb parents. Restless leg syndrome. Restless leg syndrome was also elevated to a parasomnia from provisional status in the DSM-4. It involves frequent urges to move the legs, especially when resting, in order to relieve unpleasant sensations such as itching, burning, or tingling. The urges are worse in the evening or night and are partly or totally relieved by movement. The urges may interfere with sleep onset or sleep continuity, producing daytime fatigue or sleepiness. Symptoms must occur 3 times per week for 3 months to qualify for the diagnosis. Between 2% and 7.2% of the population may be affected. Other limb movement conditions may occur rhythmically during non-REM sleep, including brief arousals that degrade the quality of sleep. Sleep-related limb movement disorders, including restless leg syndrome, increase with age. The incidence increases up about age 60, with the disorder more prevalent in females, especially during pregnancy. Finally, the DSM provides the category substance or medication-induced sleep disorder to describe the many sleep dysfunctions that can be caused by substance use, intoxication, or withdrawal. A large array of substances including caffeine, alcohol, tobacco, sedatives, and opioids are associated with sleep dysfunctions and those with parasomnias. Older individuals who take multiple medications may be at greater risk. Women seem more susceptible to substance or medication-induced sleep problems than men, given the amount and duration of consumption. Summary. There are many kinds of sleep disorders and a large number of people report having them. Sleep apnea may be caused due to obstruction in the nasal passages, failure of the baroreceptors in the organ in signaling lack of oxygen to the brain, or in the brain failing to signal the right muscles to contract for the purpose. Insomnia is inability to fall to sleep or to continue sleeping. It may be iatrogenic or drug dependent due to the disorder called nocturnal myoclonus or due to restless leg syndrome. It may also be due to several psychological factors. Disorders of REM sleep such as narcolepsy, cataplexy, hypnagogic hallucination. Disorders of REM sleep such as narcolepsy, cataplexy, hypnagogic hallucinations, and sleep paralysis have pathology in the system of neurons that secrete a neuropeptide known as orexin or hypocretin. The disorder called REM without atonia is a genetic disorder caused by damage to brainstem mechanisms that produce paralysis during sleep. The disorders of slow wave sleep such as nocturnal enuresis, somnambulism, and pavor nocturnis are more common in children. If they occur in adults or continue till adulthood, they may signal a brain pathology. It may also be a physical or a psychological disorder.